Well, welcome everybody to this month's NHIP Advanced Therapies seminar. So in fact, we have an NHIP Advanced Therapies seminar every 2 months, and the idea of our we call it a satellite, is really to encourage cross-partner research. So as many of you will know, NHIP is Newcastle University, Newcastle Hospitals Trust, CNTW, Newcastle City Council, and Health Innovation North East. And our aim is to catalyse cross-partner projects, interest, research, academic opportunities in general. So we have an advanced therapy satellite, and the aim of the satellite is to, again, catalyse development specifically around advanced therapies. And one way we do that is to have a regular seminar series. And this is one of those seminars. So I'm not going to say any more. If you want to learn more about NHIP, if you're interested, Anna Irvin can send you information. We've got a good website, which also contains lots of information, just www.newcastlehealthinnovationpartners.com. But I'm now going to hand over to Mark Jarvis, who's specifically going to introduce our speaker today, who's Kay Carruthers. So Mark, over to you.
Yeah, thanks, John. So it's a real pleasure to introduce Kay to give the talk this afternoon. Kay Carruthers, most of you know, but some of you won't, is our head of operations for advanced therapies, and she really looks after what is becoming a real complex environment across 2 GMP facilities. We've got a number of challenges to do what we do in supporting the trust and university and delivering advanced therapies, whether it's regulatory layers, infrastructure, or introducing new techniques and methods. Kay really is the driving force behind getting through those types of difficulties, and obviously with the support of the team. Kay has developed a very successful career as a biomedical scientist, and in amongst everything that we do, her real passion is cellular therapies and their clinical application. Kay was instrumental in developing the methodology around the autologous islet isolation processes that we do, and getting that back into clinical practice under the HTA. She really is the heartbeat of the interaction with our adult and paediatric clinical teams, and the collaborations that we've got in and around our bone marrow transplant service. And more recently, if she didn't have enough to do, she's trying to get her own research off the ground, looking at cell therapy approaches in bone errors of immunity. So a real asset to the department, and I'm looking forward to hearing the talk from Kay. So very much over to you.
Thank you. So I have practiced sharing this screen now 3 times, so let's see if I can mess it up. Hopefully you should be able to see my presentation.
Yes, can see that all right, yeah.
And now you can't see my notes, is that correct? Yeah,
correct.
So just the presentation. Okay, so thank you very much. I'm particularly nervous about giving this presentation, but thank you for the introduction. So when I was asked to give this, I tried to pick a suitably generic title that would allow us to cover the majority of things that we do within Newcastle Advanced Therapies. So I went for a title of Stem Cell Therapies and Beyond, which seemed all right at the time, but up until about 2 days ago, and my husband pointed out that it sounded a little bit more reminiscent of a Toy Story and a certain spaceman. So it felt only fitting that he made an appearance. So during this talk, I'm going to aim to loosely follow this guide on this slide. So I'll give you a very quick intro into who we are. I'm sure you've heard that probably 100 times before. I'm then going to try and clarify some key terminology. And then I would like to talk through a history of cellular therapies in Newcastle. And I'm going to try and punctuate that history with some interesting concepts and cases, or particular cases that I've thought are quite poignant. And then we'll just very lightly touch on some misconceptions and what the future might hold, so that hopefully by the time I finish with this, it'll be really apparent as to why I absolutely love this role and why this is a really nice job to have. So we'll start with Newcastle Advanced Therapies. It's an umbrella term, and it's a department that's been co-developed by both academic and clinical expertise. And as a result, we have two bases today. So we have the GMP arena at the Centre for Life that handles research and commercial products, which helps get them from bench to bedside. And then we have the clinically driven transplantation service at the RVI. It's two very different arenas under the umbrella of Newcastle Advanced Therapies. But what's common in that is that we have a team of individuals that specialising on one site, share practices across both, which I think gives us the edge in Newcastle Advanced Therapies. We have a lot of different staff with a lot of different expertise. So at the Centre for Life, as I mentioned, we have the GMP manufacturing facility, and you've probably heard a lot about this facility. I know Mark did a nice talk. Kath Hilkins has talked about the dendritic cell research that they've done, and that was all led, or the manufacturing of it was all led out at the Centre for Life. So this manages all the manufacturing needs of our advanced therapies. It has a growing QC lab with increasing capabilities, and it deals with the innovation, research and tech transfer from bench to bedside under the watchful eye of the MHRA while adhering to GMP practice. So it won't be the focus of my talk today because I feel like there's been a couple of talks around that. In fact, the focus of my talk today will be on the cell, gene and tissue laboratory, which that is situated at the RVI. A bit confusingly, this can be divided into two other sections. So it comes as part of the bone marrow transplant service for paediatric and adults, but also has the clinical trial service with the licensed medicines within that. They predominantly deal in process and cellular therapies. So I've used the word manufacture for GMP and processing for the RVI, and I'll explain a bit about the difference in that. They also do distribution, receipt and reconstitution of advanced therapies. And these are governed by HTA, JACIE and QAPs. So we have 3 different regulators, but similarly, despite the difference in the regulators and the difference in the work streams, the staff adhere to good manufacturing practice. So what I'm hoping to show today is how something that started off quite complex has now become incredibly routine for the clinical service, and show how it's grown to date. So very quickly, I'm going to just cover some frequently used terms, and the first one is good manufacturing practice. So ultimately, this is the corny phrase of getting it right first time every time. And this is because both sites deal in products that ultimately will be infused directly into a patient. This is not always clear cut for the cell, gene and tissue lab. When dealing with cells, you can often find yourself in a position that you've done everything correct, but the outcome hasn't always paid off. And at that point, because these are incredibly precious treatments and precious transplants, we often find ourselves having to weigh up the risk versus the necessity for transplant. And this is a little bit of a nuance specific to the cell, gene and tissue lab that not many other laboratories who deal in diagnostic medicines or blood transfusions have experienced, where the transplant is so precious that often there's no other option to give it, even if it has been compromised. So that good manufacturing practice is extremely important for us to get it right first time every time, so we don't have to deal with that. Did my slide change there? No. Has it changed now? Yes. I think you can see this. So to work in our department, you almost need a master's in terminology and acronyms. So when we have new staff coming in, they regularly remind us that we appear to be speaking in riddles for the first 6 months of their employment. So for the talk today, I just thought I'd try and clear a couple of bits up because I'm going to be using some terminology interchangeably. So when I'm referring to a cellular therapy in this talk, I'm not necessarily meaning an advanced therapeutic investigational medicinal product and not an ATIM. For a cellular therapy, if a biological treatment is based on cells, it's not significantly modified, and it's for homologous use. It comes under the cellular therapy remit, and it can be managed within the cell, gene and tissue laboratory. And we call this processing. So just a very small difference. If, however, there was a substantial modification to the product and it wasn't to be used for homologous use, then this would class under the advanced therapy, so the ATMP or ATIMP header, and would largely be dealt with at the GMP manufacturing facility. So Traditionally, for cellular therapies, we would be looking at bone marrow, cord, peripheral stem cells, and therapeutic T cells, whereas the categories for advanced therapies could be a cellular therapy, which is sometimes where I think the confusion comes from, but it could also be tissue engineered, gene, or it could be a combination of all and/or a medical device. So now this can be a little bit more muddied even further, or complicated even further, and with certain projects that we deal with, some of the more complicated projects, or for example, even CAR T therapies, where if you did a quick Google search, you'll find that CAR T, there's multiple newspaper articles referring to CAR T therapies with every single terminology on that slide. And that's just because of the development and different lab to lab differences in how they're naming or using something. Or we might encounter something really unusual like the project of islet cells, where the isolation is from an organ and then it's going back somewhere slightly different. So there's a few little elements that aren't as clear cut, but for the process today, I'm going to look at the cellular therapies, and I'm going to cover the 4 fundamentals of cellular therapy, how we've developed it, and then hopefully demonstrate how these have been precursors to the development of advanced therapies under the cell therapy remit. So I hope that made sense, because I think I've confused myself there as well. So to start with, I'm going all the way back to the start of the stem cell laboratory. So the first bone marrow transplant in the world was in 1973, and the RVI followed shortly after in 1983 with the first bone marrow transplant. And to date, we're still handling bone marrow as a transplantable option. So this is something that we still offer. Bone marrow has some advantages in that it offers a patient a full repertoire of cells. It's like a cellular rich soup for people who are suffering bone marrow failure. The donor doesn't need to have mobilization to get the harvest. And it can be considered that we all have a source of bone marrow and that it's fairly easy to get a donor for that. But it does have some disadvantages. So the harvest has to be taken under general anaesthesia, as you see in these photographs, which usually requires intubation and ventilation. Whilst there's, sorry, I've got something popping up on my screen, just grab this 1 second to get rid of that. So whilst there's 1 puncture to the skin for a bone marrow transplant, there's actually multiple punctures to the bone underneath. So donors can find that they have everlasting bone pain. Also, the stem cell counts are notoriously low. The product is quite thick, and therefore it's very easily clumped if you don't put enough anticoagulant into it. And it's rich in red blood cells, meaning that we have to be really careful about transfusion reactions when we're doing allogeneic or mud transplants. So it does have some disadvantages. In 1993, we moved to the peripheral stem cell transplant, which is what we obviously know today. This was non-invasive for the donor, and it proved to provide exceptional CD34 cell doses with negligible red cell counts. It still had a few disadvantages. The patient had to be mobilized, so not ideal, and the equipment needed was expensive. So to set up, it wasn't a cheap setup. I thought it was quite interesting that I found an article in the Lancet in 1993 that was written by our transplant coordinators at the RVI. And they were arguing that bone marrow harvesting was in fact the easiest and cost-effective method. And then they went on to express surprise that the facilities were adopting the method of peripheral stem cell transplant, which I think is really interesting, know what we know now about how the landscape has shifted in favour of peripheral blood stem cells. And also when we look at how happy this individual is being harvested compared to the previous photographs of the bone marrow where they have to be under anaesthetic. So then in 1995, we moved to cord blood transplantation. So these are early nascent cells with multipotent properties taken from the cord post-delivery. So there's not really any medical risk to the donor, there's no mobilization, and it's not a particularly invasive procedure, so it sounds like a perfect option. But in reality, collections can't be planned. It's not often you can tell the baby when to arrive. So that meant that we had to keep a suite of trained cord collectors available 24/7, which is difficult in itself. The volumes that come off are relatively small, and the counts are poor, and like bone marrow, they also contain red blood cells. So I have added a somewhat controversial advert from a private cord bank above, and all I'm going to say is that whilst we still offer cord blood as an option for transplant, and it can be used to treat multiple disease states for the reasons I've just stated, it's not the first choice of transplant in Newcastle anymore. And we are actually lucky to see maybe 3 or 4 of these a year. So this is not a common transplant, but we do still have this as part of our portfolio. And finally, of the 4 fundamentals that I said I was going to mention, this is the final one. This is the others were stem cell therapies. This is the first shift towards the beyond that I mentioned in my title. This is a T-cell therapy. So in 1999, we introduced the use of preemptive donor lymphocytes, which is a practice that still not all cellular therapy laboratories have picked up and or offer to date. The theory is that post-peripheral stem cell transplant, the chimerism of residual disease to transplanted graft can be monitored, and the donor lymphocytes can be given in small incremental doses to help slowly tip the chimerism from disease to graft, in the favor of the graft. And given the benefit, given the added benefit of a small amount of graft versus leukemia effect, but also balancing that with graft versus host disease. And I thought the best way to show that this is an advantageous approach to treatment and that it's unusual that it's not picked up everywhere else was by a case study. So in the first one we have is a 62-year-old male who presented with AML and myelodysplasia related changes. He was extremely fit for his age, but that said, the overall survival rate for this type of disease is still only 9 to 12 months. He received a mud transplant following reduced intensity chemo, and then he was managed with these preemptive donor lymphocytes just to help tip the chimerism and tip the chimerism towards the graft. This actually helped extend that 9 to 12 months by managing it that way. And here he is receiving silver medal, so the man on the right, at the World Transplant Games following all that treatment. So this is something very simple that has such a significant outcome for a patient. In addition, we also have a 38-year-old lady with aplastic anemia who started to receive immunosuppression therapy but did relapse in 2019. They had a stem cell transplant in 2020 without DLI. Sorry, it's a bit delayed. There you go. So they had the transplant in 2020 without DLI, but a matter of months later had a significant drop in their chimerism and found themselves back in hospital, but on return to hospital, actually needed managing. It was so unwell, needed managing in ITU. When they finally got her back to normal, they gave her a second transplant, but with DLI in January 2021. And here she is 2 years later, celebrating disease-free. So it just shows that that was a horrible timeline for her, where none of our transplants or our treatments took, but with the use of DLI, have taken, and she is recovering from that. So I think they're really important, and it's how something very routine can be anything but in practice for the patient. So they're the 4 fundamentals. The next thing I want to look at is how we started to take these fundamental cellular therapies and start to manipulate them. So I'm going to jump back in the timeline. These are our 2 beloved machines, one of which is going obsolete soon, that help us do the graft manipulation. And the first one in 1987 was an in vivo T-cell depleted transplant using alemtuzumab. So I'll talk more about that in a little bit, so I won't go into too much detail about that just yet. By 1996, we had introduced the red cell depletion, which allowed us to get over the barrier of the red cell component in both bone marrow and cord blood. And that's the removal of the red cells through a gradient separation. Then we introduced the CD34 selection, which was a positive magnetic selection of stem cells only, which allowed us to give top-up transplants to those who were struggling to engraft without giving any of the worry about the graft versus host disease. Then in 2002, we introduced a dextran albumin wash for these tiny little cord bloods that we were dealing with. And this is just a nice high sugar, high protein wash that allows us to revitalize the cryopreserved cells. In 2007, we introduced the CD3, CD19 depletion, which is magnetic removal of T cells and B cells. In 2012, we went a step further and introduced the TCR alpha beta depletion, CD19 depletion, which is a more specific magnetic removal targeting the alpha beta T cells specifically. Then, as one of our starting materials for a clinical trial, a manufacturing clinical trial, we introduced the CD14 selection, which is a positive selection of monocytes. And then in 2019, we introduced the CD45RA depletion, which is a magnetic removal of naive T cells. Now, I've jumped over a lot of that very quickly, but it's because I now intend to go into a little bit of a discussion about the T cell depletion strategy at Newcastle, and maybe detour a little bit from the timeline just for 2 minutes. So it's important to us in Newcastle to deal with these T cell depletion strategies for inborn errors of immunity, because we are one of 2 centres in the UK designated to treat paediatric inborn errors of immunity in autoimmune diseases. We actually have been a centre since 1978, and as it happens, we're one of the largest centres in the world for inborn errors of immunity. We're familiar with the concept of inborn errors of immunity, so I won't overdo it here, but ultimately early doors, a patient could present with 1 or more of these symptoms. And as they grow, their growth would be stunted, they might fail to thrive, and or they'll develop connective tissue abnormalities. And children with these disorders have historically had a really poor quality of life and have previously had to remain isolated from the environment just to survive, which is a term known as bubble baby. And perhaps the most famous bubble baby was David Vetter, who you see below. He was born in 1976 with severe combined immune deficiency. He died at the age of 12, having lived his entire life in this bubble setup. He actually inspired the movie The Boy in the Plastic Bubble, but in reality, most children without any intervention would die at the age of 2. But we have come a long way since the 70s, so I'm just going to try and discuss how we have enhanced that in Newcastle. So slow on my screen, sorry. So the therapeutic goal for affected patients is to restore the normal immune system. We can do this with allogeneic stem cell transplant, but one of the major obstacles of that is a lack of HLA matched donors. But one thing every child has is at least one parent who is willing to give the world to save their child. So the question that is asked is, can we manipulate the graft, a haplograft, to make it work? And this was asked as early as the 80s, when they were using soybean agglutination to remove the T cells, which is slightly different to the more modern directed monoclonal techniques we use today. So, and then the thought has moved from can we to we know we can, but is this the startings of a universal donor now? So I'm going to try and recap the evolution of this at Newcastle on the T cell depletion front. So as I mentioned, we introduced in 1987 T cell depletion in vivo using alemtuzumab. The first patient in Newcastle was a baby with severe combined immune deficiency, and the donor was the father, and unfortunately they died of adeno. And in our experience, this method was associated with high transplant-related mortality due to the toxic myeloablative conditioning, the subsequent graft failure, and then the slow immune reconstitution leading to infection. And in fact, the survival rate was approximately 58%, and if you wanted event-free survival, it was 48%. So it wasn't ideal by any means. Then in 1998, we started to look at the CD34 selection, but actually we found that this gave us quite poor immune reconstitution because we didn't have any of the other cell lines in there. So in 2007, we started looking at the CD3, CD19 depletions, but actually this caused us increased graft versus host disease. So that also wasn't ideal. Then in 2012, there's a new contender, the TCR alpha beta CD19 depletion. And this overall improved immune reconstitution. It overcame the haplotransplant barrier because we didn't have to need to worry about the HLA matching. It allowed us to give mega doses of CD34 to encourage engraftment. It retained the NK cells to fight infection. We had some delta gamma cells for graft versus leukemia effect, but then we removed the alpha beta cells, so the graft versus host effect was reduced. So this was a huge game changer in Newcastle. And in fact, this is a approximately 10 years timeline. And you can see that the results speak for themselves. The infants with severe combined immune deficiency demonstrated a comparable survival rate with an alpha beta depleted transplant against the conventional donors. And we also reported a similar survival rate in young children with non-SCID IEI. However, if you're looking at the second graph for non-SCID IEI, children over age 5 was significantly inferior with approximately 60% survival rate. And the main cause of this in this patient cohort was infection. So the introduction of the TCR alpha beta haploidentical transplant caused a shift in the pattern of donor selection and donor hierarchy. And you can see this nicely on this graph. When we introduced the TCR alpha beta in 2012, the pattern of the selection of donor changes right up to 2023. So our conventional approach was this. So matched family, matched unrelated, mismatch, mismatch unrelated, and then haplo. But actually with the introduction of the TCR alpha beta, the current IEI selection for SCID patients is matched family donor or haplo. So we're jumping straight to a haplo donation really. For current IEI non-SCID patients, it's a slightly different story. We still have matched family donors, matched unrelated donors, then haplo. So we're not quite there. But the question still is, are we getting close to to the universal donor? Is it going to be a reality? Well, not quite. So we have 3 major obstacles to overcome. The first being viremia. So the haplo transplant has a significantly higher incidence of post-transplant viremia, at approximately 80%, which you can see on this graph. And that's compared to 55% in a conventional donation. And then when you drill further down into the figures, you notice that non-SCID IEI has approximately 76%, which is compared to SCID at 33%. So this is a significant complication of these types of transplants. And then we have some complications with immune reconstitution as well. So this is the mean time that it takes for our CD3 count to get to 200 cells per microliter. And for the TCR alpha beta haplo, it's approximately 119 days, which is a significant hospital stay and a lot of time for patients to contract infection. And therefore, the third problem is transplant-related mortality in the older patients due to infection. So in 2019, Dr. Jennery travelled to Moscow and saw an innovative process, which was the CD45RA depletion. And he came back and he said, I've had an excellent idea. We're going to implement the CD45RA depletion in Newcastle. And we have a patient who needs the transplant in 3 weeks' time. So go. So the team pulled together and we got approval from the HTA and we were able to implement the CD45RA depletion for this particular patient. And what that has led to is the combined depletion protocol in Newcastle. So now we will take a donation from a graft from a donor, and we will split it and we'll do a TCR alpha beta depletion on a larger portion of the graft, and then on approximately 30 mils or 10% of the graft, we'll do a CD45RA depletion, which enables us to remove the naive T cells that are alloreactive and can cause graft versus host, but retain the CD45RO cells, which are the memory cells that have anti-infective properties, anti-tumor properties, and also carry the memories to the infection that somebody has been exposed to, which is excellent when you are harvesting the parents, because 9 times out of 10, these children are passing away from opportunistic viruses, and 9 times out of the 10, as an adult, you have already been exposed to these viruses, overcome it, and have these memory cells circulating. So then we would give the patient the standard of care, TCR alpha beta depletion. And then day +1, we would give the CD45RO as a memory T cell add back. So almost a preemptive DLI, but very specifically for memory cells. And this not only improves immune response, but also improves the reconstitution time. So this was our first patient in Newcastle. She was 11 years of age with MHC class 2 deficiency and severe growth faltering. She was completely dependent on parenteral nutrition and had multiple active infections, which you can see here. She didn't have a suitable donor. So for a patient of this type in Newcastle, our TRM was approximately 40 to 50%, so not a very good prognosis. This is the patient's results. The neutrophils engrafted on day +11 and the lymphocytes were coming along nicely by day +21. On day 19, the patient developed CMV viremia, but this completely resolved within 26 days. And actually the patient is alive and well today. Everything's resolved and has no active infections. So this was a really nice first case study for this type of process. It led us straight on to a pilot study whereby we would use chemotherapy, then TCR alpha beta depleted on day 0, and the CD45RA memory T cell add back on day +1. And the first 8 patients that we saw all engrafted within sensible engraftment times. None had severe acute graft versus host disease, and none had chronic graft versus host disease, and actually all 8 are alive. 7 had 100% donor chimerism. 1 of them did have to go for a second transplant, but it was successful. And actually most significantly what's happened is with the use of the memory T cell add back in this graph in the table on the right, you can see that the immune reconstitution time has moved from 119 days to 68, which is completely comparable of that of a conventional donor type in the MUDs. And in fact, 3 of the add backs actually had a reconstitution time of 28 days. So this was really exciting news for Newcastle and for the combined approach. It's a nice concept to demonstrate how our routine stem cell therapies are evolving constantly. And so we've just started our clinical trial in this as well in the Cell, Gene and Tissue Laboratory. So now I'm going to jump back to the timeline. So that was just a little detour to try and show you some more detail. And I'm going to start looking in 2011 at how we completely veer from cell-based therapies to something that is a tissue-based and or cell-based, but not stem cells. And this is the islet cell isolation. So in 2011, we did introduce this. It's called the Total Pancreatectomy Islet Autologous Transplant Service for short. So it's a bit of a mouthful. And this procedure can either be an auto or an allo. And ultimately, we're taking a pancreas and we're digesting it to release the insulin-producing islet cells that are transplanted, and then that's transplanted into a patient with severe or surgically induced diabetes. And it's done so in an attempt to help control the severity of the diabetes, or in best case, allow the patient insulin independence, which is usually only observed in the allo field. So the pictures here show our team mid-isolation, albeit we all look extremely relaxed, which is unusual. So that's the team that did the last transplant for the islets, and it's a big team of people. It takes a lot of bodies to perform this type of process. The top picture shows the Ricordi chamber on the left, and this is integral to the digestion of the organ. And then on the right, we have a microscope image showing the islet cells stained in red. And then on the bottom right, we have a pancreas from an allogeneic donor that is currently being perfused. And the reason I've just walked through that is because this is very different to what Newcastle Advanced Therapies sees in their autologous service. So now I'm going to try and explain the autologous service and why we are setting ourselves a bit of a challenge with this. So it's a different ball game altogether. And in fact, when we were setting this procedure up and I was traveling to other departments to learn how to do this, they were often very shocked that we were setting ourselves this challenge to deal with the autologous cohort first. So the nature of an auto transplant is that the patient has often had chronic pancreatitis and has subsequently got a very damaged organ. That damaged organ is causing them to live with really chronic pain. And it's too much. When the pain becomes too much, the decision's made to remove the organ entirely. If the patient isn't already severely diabetic at that point, the act of removing it will cause surgically induced diabetes. So our aim is to salvage as many cells from the explanted organ and return them to a niche via the the portal vein in the liver, and try and help control the post-surgical diabetes. So we do this by dissecting. So we dissect the organ in the clean room, we cannulate, and then we perfuse with 2 different enzymes. And then we pass the organ into a Ricordi chamber with silicon marbles. And through an energetic shaking motion, which often tires the staff out, we mechanically break up the organ to release the islet cells. And the full digestion of the organ can take anywhere between 20 to 60 minutes. We monitor the output constantly just to ensure that the cells that are coming off the collection aren't getting damaged whilst we're still digesting. And then when we call collection, the operators, while still rocking the Riccardi chamber, dilute the circuit to stop the enzymatic reaction. And they collect up to 8 litres of product. So this is an incredibly messy process for a clean room environment. We then go through a series of wash cycles to pellet down the cells and collect the final packed volume of tissue. And then that goes back to the patient and is infused. The whole procedure from start to finish in theatres can take anywhere from 8 o'clock in the morning till 10 o'clock at night. And that whole duration, the patient's held in theatre under anaesthetic. So it's important that we do our absolute best during the process to try and reduce the amount of time that that patient has to be on the theatre bed. So I thought I would share a recent case because I thought it was quite interesting. So this happens to be the youngest islet case in the UK, and we had to get special permission to do this patient. So he's 9 years of age and he has a gene mutation that's led him to be born with the complication of chronic pancreatitis, and he was symptomatic from the age of 4. He needed frequent extended admissions to hospital. And at 7, he required open cyst gastrostomy and a drain to the pancreatic pseudocyst. And then this was increasing abdominal pain, so he was readmitted shortly after. And then on this CT scan, you can see that he had a blowout of the pancreatic side branches. And this caused this extremely complicated word that I'm not going to attempt to say, but ultimately that it was pancreatic fluid leaking up into the chest and putting pressure on the heart, lungs, and the throat, which subsequently led to the patient having to be TPN fed since November 2023 last year. And we only managed this patient last month, so he's been on TPN since then. When we receive the organ, the first thing you'll notice is it's very damaged. It's very small. Obviously, it's a child, but it's also very small regardless of the age of the child. And just for comparison, this was the organ previously, so we were already off to a bit of a difficult start. And it's a bit hard to see on here, but you can also see that there's 2 ducts in this pancreas. So part of the complication was that you had a bit of a genetic malformation within the ducts, and there was 2 of them, which made perfusion of the enzyme extremely difficult. Post-digestion, we had approximately 50% of the organ remained, so we weren't off to a very good start trying to get the islet cells out. And this is our morphology, and I don't think it takes a genius to count how many islet cells are on that screen. So obviously this is just one field of view. There was more islets, but it's nowhere near what you would expect to see in a healthy organ. Now, we did reinfuse this patient, and everything did go well, and he is back up and about. And the best thing, whilst we don't have the outcome for the diabetic control just yet, the best thing that he said when he woke up was it's the first time that he's never had pain in his tummy. So at least we've done something, but I just wanted to try and express the difficulty that we're setting ourselves because the starting material isn't great to start with, but we still go through the full procedure and give it our best shot. So that leads us on to 2014, where we saw our first receipt and distribution clinical trial. So I'm not going to talk too heavily around harvest and distribution trials because that's that second part of the cell gene and tissue lab that I'm not touching on today. But essentially, the lab receives a harvest. It can be blood, whole blood, tissue, or stem cell products. We might process it ready for shipment, or we'll just package it up and send it to somebody who is going to manufacture. They cryopreserve it and they ship it back, and we handle the ATIMP receipt and infusion at our end. And this is a huge growing portfolio. So whilst I'm only touching on it slightly, we've gone from 2014 maybe having 1 or 2 of these to having double figures coming and going on a daily basis now in the laboratory. And then that takes us to 2015, whereby one of these receipt and distribution trials ended up being a GMO-based clinical trial. And this is something we're seeing creep in more and more. So we're dealing with a lot more of genetically modified clinical trials or products. And this one was my particular favourite. I'm not entirely sure why, to be quite honest, but we gave a standard of care TCR alpha beta depletion. But we also collected from the donor a T-cell harvest that was sent off to be genetically modified, and it had the ICAS9 gene inserted, which is essentially a kill switch, and once activated, triggers apoptosis in the cell lines. And it was activated with this ranitidine drug. I'm not very good at the pharmaceutical terminology. And I actually have a case study here of one of the patients. So this is post TCR alpha beta and T-cell infusion, and they developed acute stage 2 skin graft versus host disease. So they were given an infusion, and 1 hour post the infusion, the graft versus host had completely resolved itself. And I just thought this was a really nice pictorial representation of how powerful some of these medicines can be and some of these treatments can be. And it gave I like this model because it gave the clinicians the opportunity to give them a higher dose T-cell with the confidence that they could just switch it off if everything went wrong, which is a really nice theory. So then we cut to 2018, which is the first licensed CAR-T medicine. And again, you'll have heard lots about licensed CAR-T medicines. I'm not going to go too heavily into it here, partly because I'm sick of my own voice now, and the topic is heavily discussed within advanced therapy talks. But we have a picture of probably the most famous patient who received the first CAR-T therapy. And then we have a representation of one of the CAR-T therapies that we deal with. Newcastle was part of the first batch of UK hospitals to offer these therapies, and that was only 6 years ago now. And already we're classing them as routine practice, specifically for the lab and the handling and the requirements that we need. And then we have recently treated our 100th patient, which was in the newspaper and has some fetching photographs of our staff there. And so the observant, I've rattled through a timeline, but the observant will notice that I have a little gap between 2002 and 2007. And it wouldn't be right to do an advanced therapy talk without tipping our hat towards all the regulators. So it might be a surprise that HTA regulations only came into play with as early as 2004. So we had a long time span where we were really largely unregulated. And this 2004 introduction of HTA regulations coincided with the setup of the laboratory in the RVI building that we find ourselves in now. From then became thick and fast. So then we are under the MHRA, JACIE, and now QAPS accreditation for an aseptic facility in order to help us manage all these clinical trials that are coming through. So I said I would mention a couple of misconceptions. I think one of the most common misconceptions around this is that one size fits all. I think the feeling that the regulators are the same or are looking after the same therapy is a common thought, whereas whilst there is some crossover in the different regulators, they are individual and they are looking after individual workflows. So not one regulator oversees everything, which sometimes is a benefit and sometimes makes it very difficult for us. And then in addition, I think probably the other misconception that I hear is that these innovative therapies can't make it to the patient bedside. And I hope that this presentation has proved otherwise. Not all of the innovative therapies have a clinically unmet need, but those that do, with careful management and navigation of these regulations and the right team behind it, can make it to the patient bedside. So in summary, I have just rattled through a 40-year timeline of cellular therapies within Newcastle Advanced Therapies. I haven't gone into great detail for every element, and I've really only addressed one part of the cell, gene and tissue lab. I've barely covered the clinical trials and licensed medicine portfolio, and I haven't even mentioned the GMP manufacturing facility, so the portfolio is huge. Newcastle Advanced Therapies is one of the fastest growing departments of its kind, and I think this is a testament to the strength of our partnership with the academic and clinical teams. The speed at which it's evolving has picked up over the last 20 years, and I think this is apparent on the left-hand side with our staffing numbers. Since 2004, we really have increased our staffing and increased our workload. So in summary, we have 4 governing bodies. We are dealing with 39 receipt and distribution trials that have been complete since 2014. We have 4 licensed medicines on the book, 6 pending receipt and distribution trials, 24 active receipt and distribution trials running out of cell, gene and tissue laboratory. We offer 6 different specialised techniques, and we handle cell, gene and tissue now. Do over 300 transplants a year. we do over more than 50 specialist transplants a year, and we cryopreserve over 1,000 units a year. And so I guess the only thing left from my slide at the beginning is what's next. And we do have some interesting projects in the pipeline, including maybe organ regeneration for transplant, or preemptive cryopreservation of fertility tissues. So there's a few new things creeping through that we are being asked to weigh in on and get involved in. But I'm not going to go too heavily into too much more detail because I'm sure we're all sick and I'm conscious of my time. So I've got a couple of minutes left, so it wouldn't be right to not say a huge thank you to the entire Newcastle Advanced Therapies team, who have rightfully so been nominated for Team of the Year and Lab of the Year at the IBMS Awards. And I hope that I've given insight into what we do and how, whilst we consider our service routine, it's actually anything but. And thank you. And I think I might just have some time for questions. Thank you very much. Stop sharing.
Great, thank you, Kay. Thank you, Kay. Kat's just left a note saying she has to leave quickly for another meeting. Either people can like put their hands up and ask questions, or yes, John, go ahead.
Thanks, Shobha. Kay, first of all, thanks for an amazing presentation. You may have been nervous, but you did a fantastic job. Really, really, really impressive. I hadn't appreciated how much that you've achieved. I just had a bit of a technical question, really, because I missed it during your talk. I couldn't quite decide what the big advance was between CD3 CD19 depletion and TCR alpha beta CD19 depletion, because to me they sound fairly similar, but I think the implication was it was quite a big step change in capabilities. Could you just help me with that?
Yeah, so I think the CD3 CD19 was introduced initially to attempt to remove the graft versus host complication of transplants, actually. But what we were doing was removing all the cell lines, so all the T cells and all the B cells, and it was later found that there was some protective qualities of T cells for graft versus host. And so what we then did was we very specifically only removed the cell line that was responsible for causing that. So actually it almost backfired because it was meant to reduce graft versus host, but it actually increased it in the first instance. And then the TCR alpha beta came along and was a huge game changer and retained those protective cell lines for graft versus host disease.
Thank you. And maybe if I can be cheeky and have another quick, that really interesting case that you showed with the I can't remember what the gene was. There was a gene that was inserted that allowed you to get rid of the graft versus host disease, so you killed all the cells.
Yes.
Does that mean that transplant would have lost its benefit as well, or not?
It was only, so it would have only killed the cells of the therapeutic T cells that were given as a second, so as the ATIMP product. So the standard of care TCR alpha beta transplant would have done its job. Okay. And then as a role to try and fight infection, they had this opportunity to give. So basically they were trying to do what we're doing with the CD45RA depletion now. They were trying to give a therapeutic T cell to fight any post-transplant opportunistic viremias. But they had that safety net that if it went wrong and they caused graft versus host disease, it would just switch off the cells that had the ICASP9 gene, but retain the transplant benefit of the TCR alpha beta depletion.
Fabulous. Really amazing stuff. I mean, it's interesting from an immunological perspective, obviously, which is a lovely story. So yeah, congratulations to the entire team, to be honest. Obviously, there's a huge team behind this. But I'll sharp now.
Thanks, Kay. Anyone else? Does anyone else have any questions? Either you can put it on the chat or just shout out.
Sure, but I was looking just to where to put my hand up on Zoom, but I can't find it, so I'm just gonna chirp in.
I think it's in reactions.
React. Go to react.
Well, I'm very slow to react usually, so we'll have that. No, it's just a comment, John, to reiterate that was a pretty fantastic talk, actually, and really, really lovely to hear the evolution of this. And for me, I've been involved in this world in the dark, distant past, and then obviously come back into this environment, and to see the evolution and the step change from when I started my career to now is just fantastic. and Kay's in the middle of all of this. And really just a bit of a shameless plug, really, in the fact that, you know, we do what we do in Newcastle because we're on site in Newcastle and we work very collaboratively with the clinical teams. And we're going through a lot of pressure around infrastructure and the need for facilities. And I think what people don't realise is everything that Kay's talked about there goes through 2 small clean rooms in the RVI, which is astronomical, to be honest. You know, there are competitors in this world, like the blood transfusion service and things like that. But in the UK, we offer the broadest range of treatments and probably the highest volume. And we do that because of the close proximity and close working relationship with our clinical teams and the fantastic staff we have. So, you know, that was brilliant to listen to for me. And fabulous to see what we have achieved in actually what Kay says is one of 3 areas that we're involved in now. So yeah, top stuff.
Great. Thanks, Mark. I had a quick question, if you don't mind, Kay, and then we can close it out. So with the CD45RA depletion, what sort of conditioning are the patients getting, or they don't get any conditioning at all?
They do get a conditioning regime. It's you're gonna catch me out on this one because I'm not as familiar with the chemo regimes. It's either Campa or Grefalax is the other one, I think. And actually they're asking, so they give a full conditioning regime. And one of the biggest questions that they're asking is day +1 too soon for these transplants? And part of the clinical trial is trying to identify whether we're better off giving it at day +7 so that there's time for the chemotherapy and T-cell destructive qualities to remove from the blood supply, and then we would give the depletion because the transplant, because the concern is that we're actually just killing off some of the efficiency of the transplant we're given. But unfortunately, I can't really comment on the chemo regimes because I am only just starting to learn those.
Yeah, no, that's interesting, because I was just wondering, you're going to destroy your thymus with any sort of transplant regime, and you're depleting RA, which means what is the status of these patients in you know, in responding to new antigens that they may, you know, come across, even like simple, you know, allergies or pollen or whatever, because basically they do not have the ability to generate a new repertoire. So just wondered if there was any kind of, you know, safeguards put in for that.
Well, I guess the hope is that, I mean, I could be incorrect here, but the hope is that the transplant takes, so that they actually, because they didn't have the ability to respond to immune infections in the first place, so the standard of care transplant takes, and that we can improve their immune response, but also just fight the opportunistic viremias that we're finding is killing off a lot of our patients. But yes, I guess that's something that we've got 40 patients recruited into this trial over a 4-year period, so hopefully we will be able to say more on that in the next 4 years.
I've got a question from Matthew Cobb. He can't come off mute as he's in a noisy cafe. Is there potential developing interest in gene-modified stem cells? Just thinking of the example of LibMelD and others in the pipeline. I see a lot of interest here globally. So
I'm not familiar with LibMelD, but we do have a lot of interest in gene-modified products, some of which are stem cells, some of which are off-the-shelf cellular therapy products. But I can't comment to LibMelD because I'm not entirely sure what that one is.
Yes, Mark.
I was just commenting on that. How we interject and get involved in different projects is really dictated by our environment and the regulations we have. So we do get involved in a lot of gene-modified stem cell work, but we're handling the manufacture from other people. So we don't currently have the environment to look at viral vector and do in-house modification using viruses. So it's something that certainly the viral vector world and the combination of cell and gene therapy is where everything is going. But through this research satellite and some of the conversations I've been having with John, we would have to adapt our environment significantly to be able to look at the in-house manufacture of these things. That's not to say we can't partner with SMEs or other companies developing these technologies, and we would certainly be able to handle and process and get them to our patients.
Great, thanks. Thanks, Mark. If there are no more questions, give it a second. None. Matt has said, thanks, Mark. I could help you with viral vector support.
Yeah, I'll chat. I can chat with Matt. We've had a couple of conversations recently, but I'll have a chat with him.
Okay, great. Shall we bring the session to a close? Fantastic talk, Kay. Really interesting stuff. Absolutely amazing. Thanks, everyone.
Thank you very much. Bye.
Thank you. Bye.